Morning, everybody. And Mark, once again, huge thanks both to e-sfar and the ESICM organizing committee for the opportunity to be here and present to a small but very well-formed audience on phenotyping and antimicrobial strategy. I'm on my way from Edinburgh to London in the new year, so the travel will get better next year and I'll stay for longer. It looks like a wonderful congress. Before I start, just a few acknowledgements to my funders and any disclaimers I have. So most of the research funding is UK-based research charity, so I don't have any direct conflicts to declare here. I do have intellectual conflicts, as Mark highlighted. I do precision medicine programs, and I lead two of them called as traits, and I also do a steroid trial in ARDS. And I'm the chair of the Lancet Sepsis Commission, so I'm closely in this space, so that's an intellectual conflict, but there is no financial conflicts to declare. And advisory board activities are all managed as institutional funds. So why are we talking about this in 2025? And I think I don't need to probably convince this audience that if you think about patients coming into ICU with sepsis, I mean, we've been at it for a long time, and still 1 in 3 die within 30 days of ICU admission. And those who survive often have long-term problems, readmission, rehospitalization, infection risk, and long-term mortality. So we do need to make people survive sepsis better, and those who survive, their longer-term outcome needs to be better, and we need to figure out ways to kind of tackle this problem. So if we were to kind of keep that as our core mission as to why we are doing this sort of conferences, I thought I'll ask 2 questions that I want to discuss with you today. One is, do we know whether sepsis phenotypes that we know today, how much of microbiology information do they have? And actually, does that really matter? Those was one of the questions I want to ask. And then the second question is, what are the opportunities? Because you and me as a clinician, we start not by phenotypes, we start by a patient at the bedside. We want to do something. And that early management is guideline-based, surviving sepsis campaign or local guidelines, where we want to give antibiotics early somehow. And at the same time, as Maria highlighted, we want to figure out how do we actually get antimicrobial stewardship in there. So I kind of asked a few related questions within there, and we can kind of go through them as I speak. So let's talk about the first question. So do the sepsis subphenotypes that are out there, do they really have microbiology information? I'm not talking about meningococcal sepsis or pneumococcal pneumonia. They are very clear as to what that is. But most of the other sepsis phenotypes that we talk about. I just thought I'll start this with 2 examples from the literature. So first is this lovely paper from Emma Davenport and Julian Knight's group based in the UK. This is the original SRS, or Sepsis Response Signature 1 and 2. And this is transcriptome based, and I think you've probably heard and read this paper. It's about 10 years ago, so we know this. And I said, okay, let's look at what did they report in their table 1 as microbiology information in these patients. Now that's their table 1, and here we go. So out of the 265 patients in the derivation cohort, about 27% or about 25% of these patients had a bacterial infection. And the validation cohort, it's the same. Even lower percent had a bacterial infection. So the amount of information that you have about the type of infection that results in sepsis in these phenotypes are very low. On top of that, if you look at, there are some viral infections as well. We don't know whether it's co-infection or not. Let's take another example. This is the Mars phenotype work by Brendan Skikluna and Tom Vanderpoel's group from Amsterdam. Again, 10 years ago, this is now the standard. This is where state-of-the-art is, Mars 1, 2, 3, 4. And when you look at, let's look at the same thing. It's a transcriptome-based work. Let's look at the same thing. This is their table 1. Sadly, the table 1 has got an error. That has not been corrected, but I'll show you where the infection is. That's where the infection is listed. They don't even have the type of pathogen. They only have the site of infection. And even in the derivation and validation cohorts, the site of infection is so variable. So let's think about this. This is our state of the art. This is what we are saying is going to advance the sepsis field. And we do not have any microbiology information to define the subtype. So to really answer the question that was posed by the conference organizers to me, I think we don't know. So the next few minutes, I want to talk about should we care? So does knowing the subtype of the pathogen matter? So this is now work from, again, Tom Vanderpoel's group in Amsterdam. They kind of went back to their MARS data set and are asking the question that I am trying to answer. Do we need to know what type of bacteria are causing this infection, and does that really matter in terms of the subtype, subphenotype? So the reason why this question is important is if, let's say, for example, a gram-positive bacteria causes a particular type of subtype or subphenotype, that is useful because identifying gram-positive versus gram-negative bacteria is easier than understanding what the subphenotype is at the bedside. If it is viral infection that causes a particular subphenotype, that's important because we know that we don't need to give antibiotics, as Maria highlighted in the previous talk. So let's look at this. So this is a figure from this paper. They've used the transcriptome data and then showed us the bacteria on the right-hand side of the screen. You can see coagulase negative staph, Enterococcus, Streptococcus, Staph aureus, and E. coli. Those are the bacteria that are in their data set, and it's not what is clear from that Venn diagram of transcriptome differences between the pathogens. There is a huge amount of differences, and there is some overlap. So at this point, you could, as a researcher, ask the question, if we were to take this information and apply the MARS and the SRS endotype, will the groupings or the subphenotype separate out by pathogen? And the answer is, sadly, no. In other words, you have a problem, which is that bacterial infections and the type of bacteria that infect you matter because the subphenotype allocation has nothing to do with bacterial infection. We can do as much precision as you want. If you don't tackle this problem, you still are so far out from a precision medicine idea. Okay, so let's now think about, as clinicians, what are the kind of opportunities that you have, and what do we need, really, to try and actually be better from an antimicrobial stewardship point of view? And I think the conventional idea of precision medicine doesn't work for critical care. I don't need to explain this figure. This is a standard cancer figure, right? You take a tumor, you do a kind of PCR, and then look for a particular mutation, and then find the mutation of drugs that target the mutation and treat it. That's fairly standard cancer chemotherapy. It doesn't work for sepsis. We know the reasons why. So we need to figure out some other way. And I think as clinicians, my kind of go-to guide for treating patients is somehow let me kind of manage them, at least based on a guideline that we know people think works or does something. So I'm going to just literally take this information, this question, research question, that this title of the talk onto this Surviving Sepsis Campaign guideline. So let's think about this from an early antimicrobial management. So Maria touched on this in the previous talk. What do we need from an infection diagnosis? What does the best practice say? So they want us to figure out, because there is poor evidence, it's a best clinical practice statement. Go and find what the infecting bug is. That's what that guidance is, right? You need to find what the infecting pathogen is, because there is no easy answer to that question. So this is where the rapid pathogen diagnostics is, and that's your clinical challenge. And I think if there is things that you want to see funded from a researcher's perspective, understanding this point is probably relevant. So I'm going to give you some examples where the field is going. This is a paper from Nature Comms about a few months ago. What the authors are doing here is using not host metabolites, but pathogen metabolites, or the bacterial metabolites, and trying to understand, can they identify and differentiate between a gram-positive and a gram-negative, which is what that principal component graph shows at the top left. Are there anything that is genus-specific and species-specific, which is the figure B on the right? And then what are the metabolites? And then they come up with a library of metabolites that you could refine to understand whether it's gram-positive or gram-negative, what sort of species it is. And I think if the technological advance happens in the next few years, this will be a big kind of step change in the way we think about bacterial diagnostics. So have you ever thought about this question? Do we need to know whether there is live bacteria or not? Because that's important, right? Well, if you hadn't thought about it, let me explain why it's important. So this is a review from Blander and colleagues. I think Lies Blander is based in Berlin, I think. So what they're arguing here is if you scroll the screen from left to right, on the left side of the screen that is what we talk about, right? PAMs and DAMs and host response to infection. But actually, when you think about pathogens, there is a gradient of response. It's not a yes or a no response. Patients who have a live bacteria detected have a different host response to dead bacteria. And that's what this first part of the figure says. Soluble microbial component and dead microorganisms compared to viable pathogen, you have a different response. The reason why you get a different response is because viable pathogen does something else to the immune system that we currently don't care about. I'm not even going down the subphenotype route here because that's too complex. Nobody has actually asked this question. And there are certain pathogens that have got toxins like PVL, Staphylococcus aureus. I mean, that produces a very different response, that we know. But the question that a live bacteria produces a different response to a dead bacteria, which, by the way, both of which will be detected by your PCR or rapid diagnostics, is relevant for us. And it is not a new thing. This is 2011. That's the original paper in Nature. What the guys did was to ask the question, how does the host response differ between live and dead bacteria? And what the live bacterial presence gives you is a interferon beta and an IL-1 beta and inflammasome signaling, which is what kind of defines, if you were to dig into the biology deeper, SRS1 and MARS, that's what it is. So understanding live bacteria is important, and I think we are applying for funding to kind of understand this question a bit better in the critically ill patients. It has never been done in ICU cohorts, and I think hopefully we'll get the funding that there's a funding application including to the ESICM. So this is what we are trying to kind of address with live versus dead bacterial host response. And I think if you take this last few slides together, you could imagine a scenario where you have a host response biomarker, a pathogen biomarker, and then you can actually bring together a diagnostic. And this is a this slide looks complicated, but it's actually very simple. You know that the 16S ribosomal RNA is what we use to species identify bacteria in all of our approaches. And this paper essentially highlights to you the opportunity to kind of look at the gram-positive and gram-negative bacteria with the same IL-6 as a biomarker. You can see the gram-positive plus IL-6 separates out from gram-negative plus IL-6, and there are gram-negative and gram-positive without any IL-6 response, and there is an overlap. And in other words, you can refine the host plus pathogen diagnostics with a bit of thinking. And I think I want to make one key point here, which is when you think about diagnostics, please think about sepsis diagnostics versus infection diagnostics, because quite a lot of PCR, including the term septifast as an example. I'm just going to give an example. I don't have anything against septifast. It is a PCR-based bacterial diagnostic, pathogen diagnostic. It is not a sepsis diagnostic. So we need to kind of be very clear as to what we are actually testing and identifying. So in the last few minutes, I want to just talk about simple things that we can do as clinicians from a risk and host response biomarker. Again, this is not my invention. This is there in the Surviving Sepsis Campaign guidelines, but it's a weak recommendation against procalcitonin. And so I just asked the question, okay, if there's a weak recommendation against procalcitonin, what are people doing to address this problem? And the two contenders, this is are CRP and PCT, right? I mean, these are two have been around for a long time. And there are some clear differences from their pharmacokinetics perspective as to what these are. And the Pronto trial, based in UK emergency department, is trying to address this question using simple things like NEWS2 plus PCT as a way of stratifying risk and then giving antibiotics based on that risk. And I think the trial is, I understand that is about to be reported soon. So we probably can get some information about how to stratify risk plus diagnostics. And then last couple of slides on the choice of antimicrobials. I think from a clinical point of view, it's very clear that if you got septic shock, according to Surviving Sepsis Campaign guidelines, you need to think about broadening the antibiotics and giving antibiotic early. And they give a very simple, implementable kind of scenario where if the shock is present, just give early antibiotics. The shock is not present, do you have time to think about other opportunities to optimize patient management, and then what sort of antibiotics is really needed? And that addresses Maria's point about should we be smarter about giving antibiotics to patients. So to quickly summarize, I think I've probably run a couple of minutes over. So our current approach to evidence generation needs a rethink, because I don't think we are really answering the question that the organizers have posed me to answer, which is, do we know the relationship between subphenotypes and antimicrobial stewardship? And I think it's difficult. And I think before we get into any more precision with subphenotype-based antimicrobial choices, we need more information. And I think I've given you some examples of what sort of questions we need to address. Thank you very much.